As a unit, we had noticed that the demand just kept growing and our capacity or our staff was static. And we were always finishing late, always doing overtime, having our patients wait too long, feeling like we weren't spending enough time with the patients we had in front of us because there was still another one in the waiting room. So particularly the junior staff were feeling very stressed because that's not an easy way to do a good job. So we felt we had to change.
I think the team has long recognised that that we are unable to meet the current demands that we're facing and that the system does need to be improved.
The main drivers for change were long waiting times in our clinics, and I guess the need for us to see not only the urgent patients but also the patients that we don't initially see as urgent but have also got pressing needs for them in a timely fashion.
We had an increasing number of patients who couldn't get a clinic appointment. The list was growing. We had over 3,000 patients that haven't been able to get a clinic appointment for more than several years.
The three drivers for change were the patient, the services and the staff.
For the neonatal service, the main driver was that we were undertaking roughly 70% more outpatient attendances than we were funded for, and that raised questions of whether it was sustainable.
We run into significant resource pressures. We're a demand-driven service, and as a public service to Southern Adelaide Health Region, we've had to respond to the number of referrals sent to us by the GPs in our region, but we've reached capacity.
So for all of our patients, access to timely, patient-focused care is really important to us, no matter whether we're sending them into the private sector or into the public hospital outpatients department. So reorientation of the outpatient services is really important to us on behalf of our patients.
It's really refreshing to take time out and actually review your processes and your systems, because ultimately you can't take those things for granted. The era of being a clinician where you turned up and you just delivered clinical care is gone. To be an effective clinician now, you actually have to understand your service. You have to want to know how to deliver it better and how to improve it continuously.
In terms of our core business, it's really about thinking about what are the things that our services are needed for, and are there things that we are doing at the moment that can be done as effectively and efficiently by someone else, for instance? Can the same things be done in general practice?
We are the only publicly funded paediatric and neonatal service from Crossroads to our north as far as Mount Gambier in the south. There is nothing else. So we had to determine what other services patients could have access to within that region, such as management of attention deficit hyperactivity disorder, which could be managed for the most part by the GPs with only an annual review here, whereas a number of patients were being followed 3 monthly here by their paediatrician. So those have been triaged back to the GPs to manage that process.
So from a neonatal perspective, we've been seeing a number of community paediatric patients over many years, and we've come to the conclusion that in reality that's not our core business. Our core business is to follow up with patients who graduated from the neonatal unit and try and transfer them back to the care of paediatricians or general practitioners as soon as possible.
There are a group of patients that's inappropriate for a tertiary hospital to see, and it's really hard. It's one of the hardest things. We're saying, no, we're not seeing this patient, because we're the dermatologists and we're really careful about putting the bar up before they get to us. New patients, we have to be very careful that we don't just keep them out of habit. We actually discharge those back because they might not be needed to be seen in a tertiary hospital.
Two of the big changes across the network have been the risk stratification matrix that we've developed across each sector. The second major change has been a real culture shift for the network. Here at Flinders, at the Repat, Noarlunga Hospital and Primary Care Services, really trying to look at matching the patient need with patient services and aligning with specialist services that are available at each site.
We measured that we have emergencies. So we could say, yes, we need this many slots. Otherwise, we were always asking our guys to see one more emergency, which you're never going to not do.
Clinicians need to let the clinic staff know 6 weeks in advance if they're going to be away. If they can't let them know in a timely way, then they need to arrange for some cover for them so that the clients that are coming are still able to be seen.
There are ways of getting more use out of equipment if we change the way we process them, because the way we're currently doing is taking 30 minutes for a certain piece of equipment that we need, whereas there's a way of doing it in 5 minutes.
One interesting one is I do a Wednesday clinic and it's always late finishing, but I worked out I could actually start my clinic at a different time and somehow bring the day forward. Yet for years and years I'd always start at a certain time, so it seemed quite dramatic to move your start forward, but it's simple. Trying to get a 1 new to 2 hour review as a gold standard, but when we started we were 1 to 6. And I think that reflected that we were just too busy, we were not discharging. We've got it down to 1 to 4 most months, but I can't say all the time. And we have been able to do that based on talking about it. It's totally high profile. And I do almost jokingly say, guys, how are we getting on? Are we actually remembering to discharge people?
One of the things that we put in place in our clinics was we mandated a review by a consultant. So once a registrar has seen a patient twice, there's a mandated consultant review to ensure that that patient still needs to be in the clinic, and in many cases they don't.
One of the processes that was really pivotal to us being able to look at appropriate care, appropriate setting, was to make sure we were all talking about the same language. So defining what risk was and then working out for each organisation what that actually meant for us.
We drew up guidelines for most of the common gastroenterological problems for general practitioners to use, and essentially we made the process so that they were obliged to follow the guidelines up to a certain point, at which if the patient or the client then had not responded, then the patient should be referred to a specialist outpatient department.
Transparency in waiting times is not just important to me as the coordinator of that patient's care, but also really important to the patient to meet their expectations about when they are going to be able to be seen in the outpatient department. That if it's in 2 weeks' time, that's great, but if we find out that it's 4 months or 6 months because it's not a critically important problem that needs to be seen urgently, then we can manage that patient in the meantime using those management guidelines.
The main challenge is the initial amount of work required to provide the information for our medical colleagues, the modification of the triage criteria, the letters to the GPs for interim management are going to need to be drafted, and will obviously require quite heavy clinician input.
Well, difficulties are telling GPs or families that we're not going to be able to fulfill the request for an appointment. Usually that's not a problem, because if we can explain that we cannot diagnose auditory processing disorder, for example, that's done by other people, the GP can make a direct referral to those people. Similarly, major behavioural difficulties, if there's not a question of is this caused by a medical problem, a thyroid problem or a particular diagnosis that requires a paediatrician, then the GP can make a direct referral to a clinical psychologist. They don't need a paediatrician to do that. The GP can do a mental health care plan under Medicare and skip the unnecessary intermediate step with the paediatrician.
Trying to get people to change their ways, because when you've been doing it a certain way for many years, it's very hard to change. To do that, you need to show people data that there is a better way of doing things, we're providing the same amount of care or even a better level of care. There is always some costs associated with change, but I think in the long term that this will actually result in savings.
Sharing with my consultants the fact that there are some interesting patients that they'll be giving up and some interesting aspects of medicine that they're going to have to say, well, I haven't got the time to do that anymore. That's a small challenge, and by and large it's a challenge they can see as something which is understandable, therefore the problem is relatively small in implementing it.
My advice for other areas looking to undergo this change is that although the initial work may be very heavy and frustrating, that I think the benefits by far outweigh those.
Make sure that you know what you want to achieve, what your outcomes need to be. Make sure that you communicate effectively with everyone at every step. It has to be a team approach. There are other people involved in the process of getting the patients through the clinic efficiently and effectively. You need to involve admin staff, you need to involve nursing staff, you need to involve the patients in your discussions when redesigning your system, and you need to involve, I guess, your other customers, which may be the referrers, which could be internal or external.
Building relationships takes time. There has to be a lot of trust, and to a large extent it's not about just talking about the strengths, it's about exposing some of your vulnerabilities. There needs to be a willingness to share information and share resources, if you're able to then pull that information together and move forward.
I found the Rapid Improvement Program very useful. And I think you should use the resources that you have currently in the system. Use the skilled people that can help you with change and reform.
So it's very important that once you've completed the process, that you go back and assess what effects these changes that you've made have had in terms of your clinic. Do some measurements and see if the changes that you've put in place have had the desired effects.
I think the key approach one has to take when one's initiating change is to ensure that the people it's going to affect understand the reasons why the change is being initiated, they understand the options that are ahead, and they play a role in some way, shape or form in choosing those options. Then they own both the problem and the solution, and if they own the solution, they will implement it.
For us, it's been worthwhile. We were on a road to nowhere. We had tried the more staff option, but I guess the clinical practice improvement course said to us, forget the more staff option, you're not going to have it. So what else are you going to do? And that's when we really moved into getting interested in redesign, because we thought, well, that is a pretty true statement. Us and every other unit wants more staff.
One of the roles that we have in general practice is shared care of patients, especially those with chronic diseases or complicated problems, that with the right advice from our specialist colleagues, we are very capable of managing those patients in a shared care model.
I think what we want to do is we want to deliver a service that's of an excellent standard for our patients. That's really the key and the outcome we would really like to achieve.
What I would hope is that in the next year or two, Southern Adelaide Local Health Network will be known as the premier network for managing its outpatient services, and that the community and the staff will both be praising us for a job well done.